I'm Carlos Resende, and currently I'm the chair of ophthalmology at UT Health Science Center in San Antonio. But before I got promoted to this position, I was the director of the Diabetic Eye Clinic of the Texas Diabetes Institute in San Antonio, which is part of the university. So as a result, 100% of the patients that we were caring for at this site were diabetics. And because of that, naturally, we saw a lot of eye disease that is peculiar to diabetics or made peculiar because it's in diabetes, or they just seem to get it more often than other folks. Of course, diabetics get everything wrong with the eyeball that anyone else can get, but when it affects them, sometimes it does it a little bit differently. And of course, uniquely to the diabetics is diabetic retinopathy, which we will also cover. So let's talk about some statistics. Diabetes is really becoming an epidemic in the United States. Right now, it's estimated that 170 million people are affected worldwide. So it's not just U.S., it's throughout the world, but particularly in industrialized nations, perhaps because of the diet that industrialized nations eat and their declining level of physical activity. By 2030, the number of diabetics is expected to double. In the U.S., 21 million Americans, about 7% of the population, has diabetes, and about 1/3 to maybe as many as 1/2 are undiagnosed. In China, of course, a very large population, over 20 million diabetics. India, 32 million. And this number is really staggering. Between 1958 and 1993, the prevalence increased 5 times. And the incidence of new cases is 1.3 million. So the thing is, diabetes, there's type 1, of course, and then there's type 2, and then there are other types of diabetes. But the main groups are type 1 and 2. And type 2 is typically in folks over the age of 20. So how are the demographics? 8.7% of the non-Hispanic whites have diabetes. 13.3% of non-Hispanic African Americans are diabetics. 14.9% of Native Americans. Hispanics are 1.5 times more likely than non-Hispanic whites. But among the Hispanic group, it's a very heterogeneous group. Depends where you are, whether you're in South Florida, New York, Chicago, or in the Southwest in the U.S., that Hispanic group is different demographics. In Texas, of course, it's Mexican Americans are the predominant group, and they are over twice more likely than non-Hispanic whites to develop diabetes. So what are the first symptoms that we see in a patient who's diabetic? Well, often the symptom will precede the diagnosis. And one of the complaints that they have when they present to the ophthalmologist is, my vision blurs in and out periodically. Now, why is that? Well, there are many things, of course, that can cause this transient blurring of vision. It could be something having to do with vascularity, like maybe having emboli in the eye, but that's not typically the case. Those present a little bit differently in the history. Or it could be a problem with the tear film. Anything with the surface of the eye, of course, will give you blurring of vision that's transient. It may change with blinking or something like that. But in this case, it's vision that becomes blurry, sort of gradually, will last for a while, and then it will clear over time. So it's not quite the other transient losses of vision or transient blurring of vision. And the interesting thing is that the vision will improve with refraction. But the refraction that improves it at one moment may not improve it the following day. And the reason is it's because the glucose level in the blood is changing. When the glucose is very high, it gets into the lens in the eye. The lens metabolizes it to another substance called sorbitol, and that has created an osmotic gradient where now more fluid goes into the lens and the lens fattens up. Changes the whole refractive nature of the lens. Consequently, the patient's refraction changes. Over time, that osmotic gradient goes back to its previous status. The lens changes shape, the refraction changes again. So this is one of the reasons they keep bringing back the glasses and say, these don't work. But gee, they worked last week, and then you were seeing 20/20. Well, this time it's only 20/40, and you have to refract them again, and so forth and so on. So that's one of the early signs of that the glucose is out of control. In fact, that will be a tip that there's something going on, because at this point, they probably haven't seen their primary care provider. They probably haven't had some blood work or urine to see if their sugars are high. Another problem is difficulties with presbyopia. Now, we all know that presbyopia is not caused by age, it's just caused by the passage of time, right? So when you're in your late 30s, maybe early 40s, you start running out of arm's length. So you start using readers to help you see things up close. Well, in diabetics, that change begins to happen a little earlier. So instead of maybe 42 or 40, it may be 36 or 38 when they start having to rely on reading glasses. And the reasons for this is that the natural lens in diabetics, in everyone, it tends to become thickened and stiffened over time. That's the cause of presbyopia. That's the prevalent theory of presbyopia. But in diabetics, there are glycogen deposits that occur in the ciliary muscle, which makes it more difficult for the ciliary muscle to have an effect on the thickness of the lens and consequently the ability to accommodate. Some of these are also aging changes, but they are accelerated in diabetics, which can be exacerbated by the changes in the refractive index of the lens due to changes in its thickness due to the high glucose levels. Again, you can fix the patient. You can give them bifocals or reading glasses a little bit earlier, a little bit stronger than you normally would have for that age of the person, but we can overcome these changes. They're not necessarily always reversible, but at least we can manage them and restore good vision. Now, another thing, of course, which is very common is cataracts, and everyone, I'm sure in this room, is very familiar with cataracts, and that's the natural clouding of the lens that occurs most typically over time. For some families, in some families, it tends to happen very early, but if everybody lives long enough, everybody will develop cataracts. It's just one of those things. And the symptom of cataract, of course, is blurry vision. But blurry vision that cannot typically be improved with a change in refraction. And it can be exacerbated by glare. So on a bright sunny day, you're driving around and you're really having a hard time seeing, or worse, you're driving into the sunset or the sunrise, and the glare is just overwhelming. There are, of course, multiple factors that are involved in the formation of a cataract, but in diabetics, we know that they tend to get cataracts sooner than other folks. And they tend to get cortical cataracts, and they tend to get posterior subcapsular cataracts. And oftentimes there's a little bit of an opalescence to them, which makes it difficult when cataract surgery is done because you're having a hard time getting a nice red reflex to help you with the phaco. And of course I have a picture here of a cataract, and I'm sure all of you are very familiar with it. This is obviously another picture of sort of what phaco involves and the placement of an intraocular lens. Now, another thing that happens with diabetics is that they have the basement membrane of the corneal epithelium is not as sticky as it is in someone who's not a diabetic. Diabetic folks have a hard time healing. And as a result, if they get a corneal abrasion, it's going to take them longer for that abrasion to heal. And when it does heal, it's going to be more likely to be able to come off. I don't know if you're familiar with recurrent erosions, but this is something that occurs in folks who've had a fairly deep corneal abrasion where that epithelium is never quite adherent to the basement membrane as it was before the trauma. So minimal trauma, a drying of the eyes or rubbing of the eyes, can cause that epithelium to slough off that area that was injured. Well, in diabetics, this is more of a problem. So they'll describe episodes like recurrent erosions where they get up in the morning and they open their eyes and all of a sudden they have this severe foreign body sensation, which may go away by noon, or in some cases it doesn't, and then they'll come into your office and they'll have an abrasion with no evidence or history of recent trauma. The other thing that occurs in diabetics is that their immune system is affected. Consequently, something as insignificant to most folks as a corneal abrasion that typically heals fairly quickly, because of their affected immune system and their slower healing time, they're more likely to develop an ulcer, a bacterial keratitis. And of course, we have a picture here of a corneal ulcer with a hypopion. So patients who wear contact lenses are at a higher risk for developing corneal ulcers. We know that folks who wear contact lenses, in fact, if it wasn't for contact lenses, we probably wouldn't see too many corneal ulcers. But in diabetics, then, who wear contact lenses, that risk is heightened. Another common disease that we all see, but again, it's a little bit more frequent in diabetics, is glaucoma. And of course, glaucoma, there are many, we all now agree that high intraocular pressures is not the diagnosis of glaucoma. So really, checking for intraocular pressures is not a glaucoma test. It's a test for elevated intraocular pressure, which happens to be one of the many risk factors for the possibility of glaucoma in a patient. But there are other things that we look at, of course, beginning with visual fields, or rather visual acuity, visual fields, and an IOP check. And when we examine the patient, there's an increased cup-to-disc ratio, and there are other things that we can do. There are many other tests that are available that we can do. Use an OCT to evaluate the disc or measure the retinal nerve fiber layer and so forth and so on. But the bottom line here is that in a diabetic, you have to have a little bit greater index of suspicion for the development of glaucoma. So when you see one of these signs that we mentioned that are risk factors for glaucoma, then you have to evaluate them a little bit more thoroughly, and you have to worry about a little bit more that they might have glaucoma and require more of a workup. And interestingly enough, diabetics can get all the major different types of glaucoma at a higher risk than other folks. First, they're at higher risk for developing open-angle glaucoma. But because their lens swells up when the glucose is high, they can precipitate a narrow-angle glaucoma or closed-angle glaucoma attack, for example, where other folks can't. We have had patients who present to our emergency room with a sugar of 500, blood glucose of 500, and their chief complaint is eye pain because their pressure happens to be in the 60s and their angle is zipped. And you can go ahead and try to do a peripheral iridectomy with your laser, and it's not going to work because it's not so much that things are moved forward, it's just that the lens has gotten so thickened that it's pushed the iris all the way against the cornea and has zipped up the angle 360 degrees. What that patient really needs is emergency cataract surgery to remove that lens. They've developed a phacomorphic glaucoma, not just a run-of-the-mill narrow-angle glaucoma. Another type of glaucoma that diabetics tend to get is neovascular glaucoma. And neovascular glaucoma results from ischemic changes that occur inside the eye. And in response to the ischemia that the retina is experiencing, there's an overproduction of a substance called vascular endothelial growth factor. And I'll talk a little bit about that in more detail when we talk about the retina. But this substance causes the formation of abnormal new blood vessels. These new blood vessels form on the iris. And as they form on the iris, they also start growing into the angle, and they will obstruct the angle, close the iris to be pulled up across the trabecular meshwork, and consequently closes it completely off, and then the pressure rises. Neovascular glaucoma, again, it's typically very painful. The eye is very red. The patient's complaining of pain. They're nauseous. And the typical things that we do don't often work to reduce the pressure. Sometimes the vision is often compromised severely. The treatment really is a laser treatment to the retina, but that is not going to help bring the pressure down in the short run. Sometimes we use Avastin, which we use in other conditions. We inject that in the anterior chamber, and it causes those abnormal vessels to go away, and often helps us open the angle up, depending how long it's been going on. And we talked about open-angle glaucoma, primary open-angle or chronic open-angle glaucoma. And, of course, the symptoms that they would present, if this is the case, are typically late in the course of the disease, which would be diminished peripheral vision or even loss of central vision. Headaches are rarely caused by glaucoma. Now, they may have a brow ache or an eye ache if it happens to be a closed-angle episode or neovascular glaucoma, but primary open-angle glaucoma usually does not have any symptoms with which the patient will present. And another thing to think about are the consequences of the medicines which we use to treat glaucoma in a diabetic. Prostaglandin analogs like Xalatan and Travatan, they may contribute to inflammation in the eye. And it is thought that the diabetic macular edema, which we'll talk about when we talk about the retina, might be made worse by using some of these agents. Beta blockers, like Timoptic, Batoptic, and some of the other beta blockers, may have a negative effect on the lipid control that a diabetic often has to deal with as well. And then, of course, there's the other agents, carbonic anhydrase inhibitors, and like Trusopt, and then the systemic ones, and some of these other agents. These we don't use too often, this last group, but some of these not only obviously are an effort to control the intraocular pressure, but they may have some other systemic side effects which may be heightened in a diabetic. Of course, like in other glaucoma patients, if medications alone aren't effective in lowering the pressure, then typically we turn to surgery, and surgery can involve a trabeculectomy or actually putting a shunt, like a Multino implant or one of the other shunts that are available. In neovascular glaucoma, the scarring that occurs inside the eye is so severe that trabeculectomies are not going to work. To do a trabeculectomy in neovascular glaucoma is like doing that procedure in someone who has had inflammation in the eye before or previous surgery. The trabeculectomy will scar and the pressure will go back up. So we need something a little bit more definitive, something that will get the pressure lower and get beyond the area of scarring or inflammation inside the anterior chamber, and that's where the shunt comes in. But in patients who have very poor visual prognosis, LP vision, count fingers vision, hand motion vision, and it's unlikely that it would be better than that, they don't have a significant cataract and so forth, then instead of doing a shunt procedure, cyclodestruction is done, and you can do that either with cryo or laser. Now, we've gone through the glaucomas, but here's something that perhaps you haven't seen very often, unless you see a lot of diabetics, and that's a cranial nerve palsy. A diabetic will come in and be complaining of double vision. And the double vision could be any of the variety of double vision. It could be horizontal, things are side by side, or vertical, one above the other, or oblique, because it depends on what cranial nerve has suffered the event of a transient ischemia in diabetes. The concern, of course, is, has this patient had a stroke? Because when you examine them and you do your extraocular movements, you're going to find that there's one eye that they can't move in a certain position. And this gentleman, for example, his right eye won't go to the left. Okay, well, or is it he's looking straight ahead and that this eye won't look straight ahead. So you need to do your EOMs to figure out, to try to isolate what muscle it is or group of muscles are involved in causing the patient the diplopia. It could be the third cranial nerve, which handles, of course, the medial rectus, superior rectus, inferior rectus, and in that case the patient would have some ptosis, or it could be the lateral rectus, or it could be a superior oblique. It could be any combination. Typically, it's one nerve that's involved, and consequently, that muscle group that's affected by that nerve. One tool that you can use, one clue, is that when it's the third cranial nerve, in a diabetic, the pupil is spared. So the pupil looks symmetric with the fellow pupil, and it reacts normally. Whereas if the third cranial nerve was affected from a central lesion, like a brain tumor or a bleed inside the head, then that pupil would be affected as well and would be enlarged, would be a large pupil. So when the pupil is normal size, that's a clue that it is probably what's called a diabetic third. But that isn't hard and fast. So the concern for your practice is to make sure that this patient doesn't have some acute neurological problem that could kill them. So they may need to have some imaging study like an MRI or a CT, or be referred to a neuro-ophthalmologist for more thorough evaluation. So diplopia, new onset diplopia, in a diabetic is of serious concern. In this patient, the lid is droopy, and the patient actually can't raise his eye, bring it in, or bring it down. So it's a left third cranial nerve that's affected. Okay. Another thing that can happen in diabetics are serious infections involving the orbit. And it's typically in a patient who has very, very poor diabetic control. The sugar is sky high, and they can develop a condition called diabetic ketoacidosis. when they develop this, the whole body is having all types of metabolic changes. And one of the things that's associated with this is that a fungal involvement in the sinuses can end up spreading into the orbit. And when the infection involves the orbit, then they have an orbital cellulitis. And I don't know if you've ever seen one of these, but it's very striking. The patient typically looks ill, feels ill, so they have a fever, they're listless, they've fallen asleep, they're not paying attention to what you're asking them. The vision is typically very decreased. The eye is frozen. And by that we mean it won't move in any direction. Typically it's proptotic. The conjunctiva is very chemotic. And this is a ocular and ophthalmic emergency. And it's called mucormycosis. This patient, whose picture we have here, actually passed away. What we do in a case like this is we do an imaging study, CAT scan. We see that the orbit is full of stuff, the sinuses are full of stuff. Given the history of being a diabetic, out of control, high sugars, and we can determine by blood tests that they're in acidosis, then they need to be taken to the emergency room, to the operating room immediately. And ENT has to be called in because the way we take care of this is by actually going into the sinuses and washing out the sinuses, removing that fungus, in addition to giving them antifungal IV medications. And then an oculoplastics or orbit specialist often has to come in and help clean the orbit out as well. So this is rapidly progressive, and it's deadly. Other infections that diabetics get, in addition to mucor, which is always a major concern, is endophthalmitis. And endophthalmitis, the typical case is either post-trauma, whether it's inadvertent trauma or planned trauma like in surgery, and bacteria gets into the eye and destroys the eye. And any endophthalmitis, again, and it's an ophthalmic emergency that requires immediate action. Take cultures from the eye. You tap and inject, as we say. You go in the eye, you withdraw some vitreous, send that for examination and culture, and then you put some antibiotics in the eye. And if it's a certain level of vision, then they may require a retina specialist to come in and do a transparse plane of vitrectomy to remove the vitreous, to remove the bacteria, all the purulent material and debris that accumulate, and then put some antibiotics in the eye. And in diabetics, again, any infection is more likely to occur. So finally, we get to diabetic retinopathy. And diabetic retinopathy is the leading cause of blindness in the industrialized world among individuals of working age. Now, macular degeneration is the leading cause of blindness in the United States among older adults. But among the folks who are actively working and raising children, this is the number one cause of blindness. It accounts for 12,000 to 24,000 new cases of blindness in the United States every year. And of course, there's a tremendous cost. There's the cost to the patient who has to suffer the consequences of loss of vision, but there's a burden on society because now every time that patient comes to see you in your office, someone else has to drive them. They're no longer independent. And if they don't have a family member who can take off from work to bring them, then they start relying on social services of some form, if your county or city has that, to bring them to the facility. So that individual becomes a tremendous burden to society, to them, their family, and of course to themselves. Blindness, as you all know, means 2200 vision or worse, or really diminished visual fields. But there are other levels of vision impairment, not to the level of 2200, which are a tremendous problem for the individual. If any of you folks in the room, your best vision was 20/80, you probably could not perform the duties associated with your job. But on the other hand, you wouldn't be legally blind. So you would have to change your career. You'd have to change your lifestyle, your work, and so forth and so on. Or even at 20/50 or 20/60 in some cities, in some states rather, you can't get a driver's license. So it changes everything in your social and family structure. And so you don't have to go to legal blindness to have diabetes significantly affect your life and those of your loved ones. Diabetic retinopathy occurs in all types of diabetes, whether that individual has type 1, was diagnosed at the age of 5, or whether it was diagnosed at the age of 55 as type 2. It can occur in an individual who had a terrible motor vehicle accident and their pancreas was destroyed and had to be removed. If they have secondary diabetes, like someone without a pancreas would, they still run the risk of developing diabetic retinopathy because it's all dependent on what the glucose level is in your blood for an extended period of time. And how common is it? Well, among those who have type 1, what we used to call juvenile onset diabetics, the prevalence is 75 to 80%. It's a little bit less among type 2, and type 2 over the age of 40, it only runs at 40%. Type 1 patients are easy to diagnose. This is a child who's having all kinds of problems. A child can be like 5, could be 12. And the problem is that their body's not producing enough insulin. So their sugar is outrageously high, and they're suffering the consequences of very high sugar. And they're getting into acidosis and so forth and so on. So as a result, shortly after the diabetes begins in type 1s, the diagnosis can be made. Because of that, they haven't had diabetes for a long period of time, and their eyes are doing okay. So the recommendation is we don't have to see them immediately after the diagnosis is made if they have type 1. On the other hand, in type 2 diabetics, a lot of folks have it and don't know they have it. And when they go to the doctor perhaps once a year for a physical, the sugar might have been borderline or a little bit high, and the doctor asks them about it, and they say, well, last night it was my birthday and I had all this cake and so forth and so on. Or I had breakfast this morning and maybe that's why I had orange juice or coffee with some sugar and maybe that's why my sugar's high this morning. And it's sort of blown off and not followed up because, you're maybe borderline. So things might actually be percolating for a while before the diagnosis is officially made. So what kind of symptoms does diabetic retinopathy give you? Well, there's a spectrum. You may have no symptoms at all. You may just be experiencing some blurred vision because there would be a little macular thickening, or maybe total blindness, like no light perception. And it all depends on where the damage is occurring in your retina at that particular moment that determines the level of vision. I have seen many, many patients who have 20/20 vision, don't realize there's anything wrong with them, came in only because their primary care provider insisted that they get an eye exam, and they have horrible proliferative diabetic retinopathy, and they're about to go blind and they don't know it. And intervention is required immediately to try to salvage the vision that they do have. They've done studies, researchers have done studies where they take an animal, they make the animal diabetic, and there's several ways of doing it, and then they follow how soon the retina begins to malfunction. And actually, in dogs, for example, it's within a month that they can detect using electrophysiology instruments and some other gadgets malfunctioning of the retina that early on. So clearly, the damage precedes symptoms and certainly precedes the clinical findings that we typically associate with diabetic retinopathy. One of the roles that we have is to educate the patient who's a diabetic on the consequences of diabetic retinopathy and frankly, diabetes to the rest of their body. I think diabetic patients need to have this emphasized repeatedly, because if you ever had an illness, so a lot of folks want to be in denial. They say, it can't be that bad, or I don't think I'm not going to lose my vision, so forth and so on. But no, it's a disease that can be treated and managed, and patients do very well. My father's a diabetic. He turned 82 this month. He's had diabetes for like 35 years, and he's managed to make it without any retinopathy because my mom has been on top of him to make sure he does everything he's supposed to do. That's the way it is with a lot of folks, but other ones just blow it off. Don't take care of themselves. It's critical that people are aware of the disease and make an honest effort to manage it, and they'll do fine. So what are some of the early things that we see in a diabetic? Well, one of the early things is a microaneurysm, and they are very hard to detect. When a patient is sent to your practice by a family doc or an internist to be evaluated for diabetic retinopathy, it is quite possible that they may have it and it will be missed. Because when I look at a fundus and they're dilated, I'm looking for tiny little red dots that are barely visible in this picture. Can you see them? I put an arrow there so they could be even easier to find, and they're still tough to find. Because that patient is blinking and the eyeball is moving back and forth, and I'm telling that patient, look at my ear, and they ask me, where's your ear? On the side of my head. But I'm trying to get them to hold that eye very still so I can look everywhere for signs of retinopathy, for those aneurysms, little tiny red dots, or the little blot and dot hemorrhages, which are very early on in diabetes. But it's easier to miss. Well, if you miss it at this point, it's not that bad, because studies have shown that it's not going to progress very fast in a short period of time. And by the time they come back in a year, chances are it's not going to be too far from this stage. But nevertheless, it's important to be able to document what you see, and it's important to be able to get a good exam on the patient. But if they have a little bit of a cataract, or they're blinking on and off continuously, or their eyeball's moving, it's tough to catch these little tiny red dots. So what's a microaneurysm? Well, in the retina, in between those arteries and veins and the venules and arterioles that we can see most of the time very clearly, there's a tremendously intricate capillary bed that we cannot see with our instruments, and even on fluorescein, sometimes we can't see those fine capillaries. But in those capillaries, they're wide enough for a red blood cell to fit through one at a time, and they have walls. Well, the walls in diabetes undergo two changes. One, the walls thicken. The second thing is that they become more permeable to the fluid and the substances in the blood. They lose pericytes, which are these cells that line the wall of the capillaries and regulate how the capillary is functioning. Ideally, you only want oxygen to leave the capillary and nutrients, and the stuff like carbon dioxide and other things that aren't necessary in the tissue to enter that capillary and then move out. But in a damaged blood vessel, what occurs is that these aneurysms form, red blood cells then start to accumulate there, and they can actually end up slowing down, and along with platelets, they'll form a clot, which will then block the flow of blood through that capillary. In addition to that, they are leaking all these substances out of the capillaries, out of the blood vessels that should not be leaking, particularly a lot of lipids. So that's why you start getting some of the yellow deposits that form, which we call hard exudates. And you can see these arrows at the hard exudate here. The other thing that happens is that these damaged capillaries become very fragile. Because they become very fragile, they easily break. And when they break, the red blood cells and everything else goes into the tissue. Now, most of the serum is transparent, so we can't see it. But the red blood cells we can see. And they form one of two types of hemorrhages, either blot or dot hemorrhages, or what we call flame hemorrhages. And it all depends on how the red blood cells line up. On the outer layers of the retina, where the photoreceptors are, the rods and cones, those cells and the ones just in front of those are lined up sort of perpendicular to the wall of the eye. As a consequence, the red blood cells line up like pennies in a penny roll, one on top of the other. So when you look at them, you're looking at them end on, they look like a dot. Okay? Or a little blot, but it's sort of round and it has distinct edges. When the red blood cells break out into the retina, but they're in the inner layers of the retina, the tissue there is going parallel to the wall of the eye. So the red blood cells line up in these parallel rows, and it looks like someone took a brush with red paint and just made a stroke. So they look like a flame or a paintbrush, a paint stroke on the retina, and you can see some of those right here. So when you look at the fundus, you say you're doing a fluorescein angiography, you're taking fundus photos, and you see these things, well, then you know that the heart exudates are the lipids in the blood that are coming out of the vessels because the vessels are damaged, and they're damaged because of the high sugars. And when you see these hemorrhages, you also know that those are occurring because the blood vessels are weakened and are broken, and the red blood cells are coming out. Now, I mentioned how the capillaries get clogged, and then you have this clot that's not letting blood flow through. Well, if that happens to a large enough area, the tissue beyond it is no longer getting oxygen and nutrition. So now, like when the brain doesn't get that, you have a stroke. When the retina doesn't get that, it has an infarct. It's a small area of stroked retina, and that appears as a cotton wool spot or a nerve fiber layer infarct or a soft exudate. All three of those mean the same thing. If that area of damaged capillaries is large enough, then that area becomes what we call capillary dropout, which means there are no longer capillaries there. It's an area of non-perfusion, retina non-perfusion. And perhaps when your doc goes over a fluorescein angiogram, it uses those terms, area of non-perfusion or capillary dropout. And that's implying that no longer is blood circulating to that part of the retina, which of course means it no longer can function. Now, you have an artery, and these are some infarcts here, the cotton wool spots, and also some flame hemorrhages. Now, what happens is that the heart is still beating, is still pushing blood into the eye. That blood is going through the arteries, and it has to exit through the veins. And the way it gets to the veins is by going through that capillary network, right? But now you have chunks of capillary network that aren't there because they're gone. So the blood starts getting backed up into the eye. And it's trying to find other avenues to get across, just like when you're driving to work and you're on the main highway and there's a traffic jam, you try to look for collateral routes to take to get to work. Well, that's what the red blood cells do. But when they start going through these other little neighborhoods to get to the other side, those remaining capillaries start having to carry more red blood cells. As a consequence, they get stretched out. They get a little bit tortuous, and they form something that we call intraretinal microangiopathy, or IRMA. And I'll show you a picture of those. They look like enlarged capillaries, or like little veins that are kind of corkscrewy, but they're flat in the tissue. Okay, they don't stick out into the vitreous like neovascularization does. In addition to that, by the time those red blood cells get to the other side, they get into the vein, because the volume of them is not as great as when the capillaries were intact, there isn't that push for them to get moving out of the eye. So they sort of stagnate there. The veins then become tortuous and beaded, almost like sausage links. And you have venous beading. And this area here, you see how there are no blood vessels? They're all cut off. This is an area of not only capillary dropout, but actually the arteries and the veins have also disappeared due to damage. They might be there, but they're just incredibly thin, and you couldn't even see them even with a fluorescein angiogram. You can see this whole area here, how it compares to some of this area here. And here you see those corkscrewy vessels that go from the arteries into the vein, and those are IRMA. Those are the ones that have to do the work of getting the blood cells from the red blood cells from one side of the vascular system to the other. And you can see how this vein is beaded. Again, because the blood is not moving very fast. So then, all these different findings give us a clue as to what level of retinopathy the patient has. And the reason that is important is because by classifying the level that the patient happens to have at that moment is predictive of how soon they will develop the next level. Because ultimately what we want to be able to do is intervene with laser when that intervention is going to have a positive effect on the course of their disease. So that's the whole reason we examine diabetic patients for the retinopathy status. So the first group is we've termed non-proliferative diabetic retinopathy. And within that group, there's minimal, mild, and moderate. Minimal, we just see the little red dots, microaneurysm. And mild, we have some microaneurysms, but we can also see some hemorrhages and maybe some exudates. And in moderate, we're getting more hemorrhages, more microaneurysms, and more exudation, and maybe some cotton wool spots and other signs of ischemic retina, which are the cotton wool spots, the IRMA, and the venous beading. When we get to that point, and we see a lot of it, then that goes from the leaking or the vascular incompetence or increased permeability stage to one of ischemia or lack of oxygen. And now we are into severe non-proliferative diabetic retinopathy. If a patient has one of these two, then we probably see him back in a year, maybe 8 months, 6 months, depending on our gestalt of what else is going on with the patient and what their level of glucose control or so forth is. But typically, annual exam is okay because that's about how long it's going to take for them to advance to this stage. If they're a moderate disease, we may see them every 6 months, 4 months, or 3 months, depending on how severe those changes are. Once they go into severe non-proliferative diabetic retinopathy, we see them at least every 3 months, and sometimes a little sooner depending on the patient. Now, something that can be happening all along those other stages is macular edema. And macular edema can occur anywhere there are leaking blood vessels. It just goes into the tissue and the tissue swells up. But when it occurs within certain parameters, then we call it clinically significant macular edema, and that meets criteria to be treated with focal laser. So another thing we're monitoring is the presence of macular thickening that meets the clinically significant status. Now, by looking at this picture, can you tell that's swollen? I can't tell because the picture only gives you 2 dimensions. So you need a 3-dimensional view. You can do it by doing a fundus photo in stereo, where you alter the angle a little bit of the camera, and then you'd have to have a stereo viewer to see the picture, whether you have slides or you're looking at on a screen, or you examine the patient with biomicroscopy, which means using a slit lamp and a 78 or a 90 diopter or a 60 or a 66 diopter lens in front of the slit lamp, between the slit lamp and the eyeball. So your doc would do that to determine if that area is thickened. Because if it's not thickened, intervention is not indicated. 20-some years ago, they did a study that determined what the criteria had to be to make the laser worthwhile. Otherwise, the treatment was not helpful. Eventually, the ischemia is so severe that the eye starts producing, that the retina starts generating a higher level of a substance that's very important. It's called vascular endothelial growth factor, or VEGF. Now, VEGF is present in us all the time. It helps blood vessels form where they have been damaged. But the problem is that some of those vessels, we don't want them to form, and we don't want them to form in the eye. In an area of ischemia, the tendency is for new vessels to form. And when they form not around the disc, we call it neovascularization elsewhere, or NVE. And you can see some here and some here. And again, their appearance is like if you took a piece of red yarn and you put it between your palms and you went like this so that it's all tangled and jumbled up. There's no rhyme or reason to their development. They're not being helpful because they're not really providing the oxygen to the tissue that you want. And here's really profound neovascularization at the disc. And here again. Now, why is this a bad thing? Well, it's a bad thing because that neovascularization will progress and eventually cause scarring. Some of the vessels will fibrose. As new areas develop, the old areas fibrose, and it's growing into the vitreous. As it grows into the vitreous, it starts scarring, it starts contracting, it pulls the retina, and it will detach the retina, and you get a tractional retinal detachment, which is what these pictures are. Those abnormal vessels are incredibly fragile. So if you sneeze, you cough, or you try to move some furniture at home, the elevated increased blood pressure that you will have will cause that very fragile abnormal vessel to break, and then you'll get a vitreous hemorrhage. And it can be relatively mild, like this one, which just covers the macula, so now the vision is 2200. Or it could be profound, filling up the entire vitreous cavity, and the vision is bare light perception. %50 of patients with severe NPDR, non-proliferative disease, will develop PDR within 1 year. Thus, the need to see them frequently. Over 700,000 persons in the U.S. have PDR, proliferative disease, and 65,000 cases develop annually. And we've covered why it occurs. How can we prevent it? Well, it's not the challenge that we have is that there aren't too many things that we can do. I mentioned the VEGF, and it's not just one substance, but there's a whole cascade of substances that work together to lead to the elevation of VEGF and the formation of abnormal vessels. And VEGF not only causes abnormal vessels to form, but they also cause the current vessels that are there to become very leaky. I'm not going to go over this quickly. Sadly, there's no magic bullet. Your patients come in with a cataract, and they know that cataract surgery will help them. They come in with glaucoma, they know that you'll put them on drops, and the glaucoma will go away. They'll come in with diabetic retinopathy and expect, again, some procedure, some medication. In some cases, they'll even say, well, how about glasses? Won't glasses help? Well, the sad thing is, of course, is you know that none of that's going to help. We cannot reverse the damage that diabetes caused. The most we can hope for is to stop the progression or slow it down. Any drug that we come up with, for example, Avastin or Lucentis, they work great in macular degeneration. We can also use them in diabetes and make these blood vessels go away. But both of those medications, particularly Avastin, can have an effect on a heart that's recovering from an MI, from a heart attack. It can keep that heart from revascularizing. So they've found that even if you inject Avastin in the eye, you can pick up some of it in the systemic circulation. So consequently, whatever you put in the eye ends up everywhere else. So every medication we come up with that might have a beneficial effect on the eye could have a potential negative effect elsewhere in the body. And it's that balance that the body maintains so well that is deranged in some disease process that we have to sort of restore. The best, of course, is prevention. And the way you achieve prevention is by controlling glucose. And this is something that, from the person at the front desk who greets the patient to the person at the end who sends the bill, everybody has to participate in educating our patients in what they need to do to prevent from going blind, and that's to control their glucose. Whatever the doctor, whatever their endocrinologist or internist or family doc tells them they have to do to control it, they need to do it. And there's a series of studies that have come out that support the fact that if you control your sugar, things will go better. There's the DCCT, and I'm not going to go through all the details, but the bottom line is if you take patients, either type 1 or type 2, the DCCT involved type 1 patients, the study that was done in the UK involved type 2 patients, and you take diabetics and you very tightly control their glucose because the patient's taking insulin several times a day, or they're on an insulin pump, or they're watching what they eat and they're exercising. They're doing all these things to maximize their sugar control. The likelihood of the disease progressing is dramatically decreased. If they don't have it to begin with, the chances of it developing is way decreased, and if they have it to begin with, the chances of it progressing is decreased. And one of the things that we look at is hemoglobin A1C, which is a blood test that is done that gives us an idea of how their sugar has been doing over a 3-month period of time. And if the level should be less than 7. You can see that the higher it is, the greater the risk of them developing problems. What other things can affect diabetic eye disease, retinopathy in particular? One is blood pressure. We know that blood pressure, elevated blood pressure increases the risk of diabetic retinopathy, and a couple of studies have proven that. Pregnancy. If a woman is pregnant and a diabetic, even if they have mild disease that you would normally wait a year to see again, the woman really needs to be seen every 3 months because the disease progresses much more rapidly during a pregnancy. Elevated lipids, elevated cholesterol, triglycerides, these also increase the risk of diabetic retinopathy. So those need to be controlled. And these are studies involving lowering cholesterol and the beneficial effect that it had on diabetic retinopathy. Anemia is another risk factor. There's a lot of patients that have chronic anemia. Well, that is contributing to the development of their diabetic retinopathy. And we talked about the ethnicity. It's higher in African Americans, and it's higher in Hispanics. Conditions, amazingly enough, that don't cause progression of, don't contribute to diabetic retinopathy include smoking, alcohol use, increased weight, sedentary lifestyle, or socioeconomic status. Now, I don't recommend that you go out and smoke and drink because you're not going to get diabetes, but studies haven't supported its contribution to retinopathy. And again, the key player here is the primary care provider and getting the patient to do all the things that are necessary to keep their sugar under control to avoid retinopathy, but I cannot overemphasize our role in the eye care business to make sure that we reinforce that. And how should the exam go? It should be a complete, dilated exam. In other words, on the fee sheet, it's a comprehensive eye exam. The whole thing needs to be done. Type 1 diabetics should be seen within 5 years of their diagnosis and then annually. Type 2s should be seen every year. Now, there have been some studies that suggest that if they don't have any retinopathy at all, then you can see them every 2 years. And that, I think, is reasonable. On the other hand, if the negative aspect of this, if you tell the patient, oh, I don't need to see you for 2 years, they think, this is not a big deal. So having them come back every year really emphasizes how critical this is. If they have retinopathy, the frequency of the exam is determined by the level of retinopathy, as I mentioned earlier. And again, we can't treat it with drops, oral medicines, or eyeglasses. Blurred vision secondary to diabetic retinopathy cannot be corrected with glasses, because that's one patients always ask, and there's no cure. The damage is permanent. A couple of things about laser. Laser does not improve visual acuity. The studies that were done were not using improvement in visual acuity as an endpoint, but simply lack of progression of disease. And diabetic macular edema, these are the criteria that we follow or look for to determine if the patient has clinically significant macular edema, and it falls into these 3 categories. This diagnosis is not made with fluorescein angiography, and it's not made with an OCT. Those are tools to help us evaluate where we need to treat and whether the treatment was successful. Because an OCT, for example, the macula can tell us if that thickness decreased over a 3-month period of time after we treated it. But it is not how the diagnosis is made. The diagnosis is a clinical diagnosis. And this is a patient where I treated the thickening here. I could find the aneurysms. In fact, I didn't even need an IVFA to find them. And over a 6-month period of time, the thickness went away and the exudates were absorbed. Some of your docs may be using triamcinolone injections in the eye, Kenalog. Kenalog has a limited role in severe diabetic macular edema, but the problem with triamcinolone and some of the other injections that we use to treat diabetic macular edema, like Avastin or Lucentis, even though those are off-label uses, as it is for Kenalog, is that these require repeat injections. They're not cures. Sometimes it's every 4 months you have to stick another needle in the eye, or every 4 weeks rather, or every 6 weeks. Rarely can you just do this for a while and stop and have the disease not come back unless something else dramatic changes. Of course, the treatment for proliferative disease is pan-retinal photocoagulation, which what it does is destroy the peripheral retina to keep it from producing the VEGF that leads to all the complications. And when you can't see the inside of the eyeball because you have a vitreous hemorrhage that's been there for 3 months, then you do a vitrectomy. If you have a tractional retinal detachment, again, a vitrectomy is what's required. And some of these things that are being evaluated are Macugen, which was typically used to treat macular, age-related macular degeneration, Avastin, which we've talked about, and Lucentis. These last two are antibodies that keep VEGF from functioning, and therefore that stimulus for abnormal vessel production is eliminated. Then there's these other agents that have been evaluated to again interfere with the function of VEGF. But regardless, all of these things that we do, it's only temporary. There is no definitive cure. And things that may help are if you put a dexamethasone inside the eye, so you don't have to keep a little sort of tablet of dexamethasone inside the eye, slow release, keeps you from having to inject the eye with triamcinolone on a frequent basis. This is a product that Lilly's working on that is an oral agent that may actually decrease the production of VEGF in the eye due to its interference with a cascade of activities, but again, it's being studied. It's not ready for prime time. And some other agents may actually contribute to macular edema. One of them is Avandia, which is rosiglitazone, which is a new class or newer class of diabetic agents. Future therapies also include studies that have found that the vitamins and antioxidants that we tell patients to take when they have macular degeneration may have a positive effect on the course of diabetic retinopathy, macular edema in particular. Screening is something that's attempted in a lot of places where there aren't enough eye care providers to go out in the community to take care of a lot of people. In South Texas, for example, we have great areas of territory that there are no optometrists or ophthalmologists. And what we have done is set up photo screening places where the patients can go have their eyes photographed. We have a technician who does the photos, checks the intraocular pressures, does a quick slit lamp exam, and then relays all this information to us via telemedicine. We evaluate the data and then determine whether that patient needs further evaluation or not. That's one way we can provide outreach for the community that doesn't have anyone there to do it firsthand. But the problems with screening is that if you don't have a mechanism for the patient to get their eyes taken care of after you find disease, it does no good. So they still need to have access to eye care. That's it. And